more and more about the implant procedure. And this had induced, in 2021, more than 150 implants company in the world. 2023, more than 200 brands. And I like what John DiPonziano said. The success that modern dental implants enjoy today is surely linked to our ability to grow bone. I can add, if we're gonna use also the minimal invasive surgery procedure or technique. We know all, in most of our cases, the patient present with bone resorption to place an implant. Like we saw here in this case, bone resorption after premolar extraction, and here we have severe bone resorption after premolar extraction. After extraction, the patient disappeared, and he will return after 1 year, 1 year and a half, after 2 years, asking to restore his missing tooth or his missing teeth. And he comes with severe bone resorption, like we saw here in the upper jaw, or severe bone resorption in the lower jaw, and is asking to place an implant. And we know all that more than 40% of osteointegrated implants require bone grafting, and especially in lateral bone augmentation. And so we have various augmentation techniques to treat this bone resorption. And all of these techniques have an impact on bone regeneration. And we know all that these techniques are very traumatic and aggressive for the patient. We have two ways to proceed for lateral bone augmentation. The first way, GBR while implant placement. That means put the implant at the same time, put the bone grafting, bone material, and cover the surgical site with membrane, any kind of membrane. Close, and after 6 months, open again and proceed to the crown. The second way to proceed is to delay to put the implant. That means make the bone grafting now using autolog, heterolog, alloplastic materials. We can fix or using the pins, the screw. We can cover the surgical material, the bone material with any kind of membrane, collagen membrane, for a PTFE membrane, titanium membrane, for example, and fix this membrane with a screw or with pins. And close. After 6 months, open again, take off the screw, take off the pins, and take off the membrane, and put 2 implants. And then close. After 2 months, open again, and proceed to the crown. But we know all that only the literature agree that the use of autogenous bone graft still remains the gold standard. And we make last time a little difference, the comparison between the use of bone block and the GBR. And we have demonstrated that the use of bone block, we have more positive results than the GBR technique. But in bone block, we have morbidities and complications. In bone block, it's 2-stage surgery technique and 2 surgical sites. In GBR, we have less positive results, but it's 1-stage surgery and 1 surgical site. But the guided bone regeneration is a successful, well-documented and technique used for procedure for treatment of alveolar bone defects in conjunction with implant treatment. A systematic review report that we have 95% of implant survival rate after horizontal or vertical bone augmentation. Several reports have indicated that the survival rate for implants placed sites augmented with GBR is the same with implants placed in pristine or perfect sites. This technique, we know all the GBR. We should put the implant in the right position, in the right place. Surely we'll have exposed threads because we have severe bone resorption. We should have the primary stability. We put our bone grafting around the exposed threads. We cover all the exposed threads, and we cover all the surgical defects using any kind of membrane, collagen membrane, PTFE membrane, titanium membrane, for example, and close. And we know all that if we're gonna use the collagen membranes without titanium reinforcement, tend to collapse. That means lose the volume in large reconstruction because they do not have adequate resistance to space maintenance. Like here, for example, we have severe bone resorption after tooth extraction. I put two implants. Surely I will have exposed threads because I have severe bone resorption. I cover these exposed threads with bone material and I cover all the surgical defects using the collagen membrane. And after 1 year, I have a collapse because I use the collagen membranes without titanium reinforcement. Studies show satisfactory results for bone reconstructions with titanium or PTFE meshes. Like here, for example, here in the defect, we use the bone material and we cover with titanium membrane. Here we cover with PTFE membrane. After healing, we maintain the volume during healing period without graft compression by the flap. So if we have to use any kind of membrane to cover the surgical defects, collagen membrane, titanium membrane, or PTFE membrane, we should stabilize this membrane. Because cover the defects with no stabilization, the maximum bone gain is 87.6%. And when we have to cover or when we have to stabilize this membrane, we should use the pins or screw. And when we have to stabilize this membrane, we should open a large surgical site, a large flap, buccal flap or palatal flap, buccal flap or lingual flap. We should open a large defect. So we can put the bone grafting, cover the bone graft by the membrane, collagen, PTFE, or titanium membrane, and fix this membrane by screw or by pins, buccally or lingual, buccally or palatal. And sometimes we have to use the wallet technique to fix this membrane, to use the pins, which is a very traumatic and aggressive technique for the patient. These conventional augmentation techniques, bone block and GBR using titanium and PTFE membrane, require extensive knowledge and experience. The more complex the procedure is, the higher the chances for a post-operative complication. And what the patient need now. We showed this slide many times last time because it's very important to know what the patient need now. The patient is asking for one-stage surgery, reducing the surgical interventions, reducing cost, reducing the healing time, and shorten the treatment time. All of this lead for greater patient comfort and increased patient acceptance of implanted treatment. And that's why the patient actually is demanding more and more about the implant procedure. And especially when we're gonna explain to the patient that we're gonna use the minimal invasive surgery technique. And this is what Austin provides for us. Austin provides for us what we need, the OssBuilder, called the Smart Builder. It's a perforated titanium mesh membrane. It's built to promote bone formation. The cut edges of titanium mesh sometimes cause mucosal irritation that lead for exposure of the membrane that cause infection. It's not the case with OssBuilder. Why? Because with OssBuilder, the external form is round to avoid damaging the flap. The surface smooth to avoid bacterial colonization or infection. Lipid second stage surgical procedure with minimal incision. We're gonna see how. No increased patient morbidity. And 3D preform design does not require trimming or bending. And this is very important. And this is what the patient needs to decrease surgical time, to decrease healing time. We have three shapes, three design of this membrane. We have the shape one wall. That means design to treat the one wall defect. For example, the buccal defects like we have here. We have the design two wall, designed to treat the two wall bone defect like we have here, for example, buccal and proximal defects. And we have the three wall defects designed to treat the three wall bone defects like buccal, proximal, and lingual. And we can use this membrane without releasing incision or with very minimum releasing incision for less post-op swelling. And this is what the patient needs. And we have different measures. We have different shade, different design, and different measure. That means during the surgery, we can check the surgical site, the surgical defect, choose the adequate membrane, take the measure of the membrane, and cover the surgical defect with this membrane, which does not require trimming or bending. Again, decrease surgical time and decrease shear time. We're gonna see now by movie animated how we can use this membrane. We take the proximal buccal width. We have exposed threads here, and we take the length. We check the exposed thread, and we check the side, and we can choose the adequate membrane. For example, wall membrane, and we can take the measure. That means we put the implant. First, we should have our primary stability. We should have our primary stability to put the implants. And we will have the exposed threads because we have severe bone resorption. We connect this as the anchor. We connect the anchor to this implant. We put the bone material around the exposed threads and around the anchor. Then we cover all the surgical defects with this membrane, with the OssBuilder, and we stabilize this membrane using the healing cup or the cover cup. That means we don't have to make a large surgical site. We don't have to open a large surgical site. That means a buccal flap or lingual flap, buccal flap or palatal flap. We don't have to fix this membrane using screw or pins. We just open flap to can see, to can put the implant, put the bone material, and cover the surgical defects using this membrane. And we stabilize this membrane using the cover cup. No need to open a large flap, large surgical site to use pins or screw. That means the use of OssBuilder do not require tension-free flap in most of our cases. A lateral augmentation with OssBuilder becomes a simple and predictable operation. The post-operative complications are decreased significantly comparing to other technique. And you can try it. And this is what the patient needs. The same slide, very important slide. The patient needs to reducing the surgical intervention, reducing cost, reducing healing time. The patient asking to reduce his discomfort after surgery. Dear friend, you know, and dear colleague, you know that the patient knows everything today. He can go on social media. He can go on Google. He can make his own research and he can come to our clinic. Doctor, I see this on Facebook. Doctor, I saw this technique on Google. I need this technique. Doctor, do you use this technique? The patient knows everything. And especially when we're gonna explain to the patient that we're gonna use the minimal invasive surgery technique while we're gonna make the lateral bone augmentation. This minimally invasive surgery, its economical surgical technique, is aimed at improving post-operative comfort for patients while permitting widening of the lateral bridge. So we have comfort and safety to use this kind of titanium membrane. Now we're gonna move for some clinical cases. This is woman, 43 years. She came to treat her mouse. We have missing premolar, missing upper molar left. We have to extract the central, lateral. We have to extract the upper right premolar, molar, the lower right premolar, and proceed to remove the prosthesis or fix prosthesis after replacing the implant. The patient refused the removal prosthesis. And because of dental anxiety, the patient doesn't want to make any surgery, doesn't want implant. So she left. And she recame after 1 year. Doctor, do you change your mind? Do you change your treatment plan? At my clinical exam, I have here the patient. She restored her lower jaw with molar, premolar, molar, premolar, and canine. She made a fixed bridge. Up she lost her bridge. We have remaining root, lateral, central-lateral, premolar, and molar. So, do you change your mind? No, I didn't change my mind. Extraction of the remaining root, premolar, molar, removal prosthesis, or put an implant. She left again, and she returned after 2 years. Doctor, do you change your mind? You change your treatment plan. This time, she lost her bridge canine. And look what she had here. She make implants, premolar and molar. So, after 3 visits, I managed to convince the patient to make implants. So, we proceed. We put 3 implants, upper anterior, 3 osstem implant. We have exposed threads, covered by bone grafting, and covered by collagen membrane. So the same thing, right upper, and I connect the crown to these implants. So the patient return after 1 year and a half for checkup. After many calls, and look at the clinical exam, gingivitis around the normal crown, normal ceramic, the tooth, the implants, no hygiene, no maintenance. She didn't take care about her hygiene. What she wants the teeth. She wants to restore her smile and restore her mouth. She didn't take care. And what do you expect when you see this? Peri-implantitis? I take 2 X-ray, right and left. Right here, I did my implant. I use the switching platform. And here, they use the normal platform. Look at the difference. Here, I have bone remodeling around the neck of the implants. But here, we have bone resorption around the neck of the implants. But the patient, she didn't came for checkup after 1 year and a half. Why she came? She came because she started feeling moving the lower bridge, the mobility. Look at the lower bridge. We start like this, and she make a bridge from premolar until canine. Now she start feeling the moving the bridge, and she came for checkup. So we should extract the premolar, take off the bridge, and make implant. She left again. She returned after 9 months with no bridge, the bridge in her hand, no premolar, no molar, severe bone resorption, and with the remaining root of the canine. Doctor, do you change your mind? Any treatment plan? I made here, I asked for CBCT image, was taken to evaluate available bone at the site. And look what I have, severe bone resorption. So here we have to make a lateral bone augmentation before we put the implant. The lateral bone augmentation can be complex challenges for the clinician. Different factors need to be considered when choosing the technique to expand the ridge laterally. Ideally, the technique should facilitate the goal of ridge width, increase while reducing inflammation and postoperative pain for the patient. So the same slide, it's a very important slide. What the patient need? The patient need to reduce surgical intervention, reduce cost, especially the cost, reducing healing time. The patient, she's asking to reduce his discomfort after surgery. And especially, she's demanding about minimal invasive surgery technique. Rodney Norman said, if I had known better, I would have done it differently. But I didn't know better and did what I did. So now I know better. We have various augmentation techniques to treat this patient. At this time, I didn't know about OssBuilder, so I go for traditional technique. I propose here bone block or bone material covered with titanium membrane, covered with PTFE membrane. The patient refused. She doesn't want any surgical treatment, so she left. I didn't catch her from there. Second case, 56 years, old women patient presented with desire to restore her smile. Why she came? She came because she started feeling diastema between the two centers. Something wrong here. At clinical exam, she told me that she restored her mouth since 3 years. And now she started feeling something wrong between the two centers. At the clinical exam, look what I have. Diastema between the central, that's why the patient she came. Missing premolar molar, no occlusion left, and no occlusion right. I have recession on the implant. Recession, or I can say they put the implant in the wrong position. They put the implant where they have bone. Normally, after lateral extraction, we will have bone resorption. Here, they put the implant where we have bone. But where we should put the implant? We should put the implant in the normal position. The implant should replace the missing teeth, the missing tooth. We should put the implant in the right position, and then we make the construction by bone grafting or tissue grafting. Here they put the implant where they have bone, and look at the results. No premolar, no occlusion, right, left, and look at the lower prosthesis. The patient told me that she made at the same time the lower prosthesis, but after finishing her treatment, the patient didn't like her mouth, didn't like her smile. She asked why we have here a recession on implant. Why I can see the implant. They told her this is the only way we can put the implant because you don't have bone. The patient, she accepted the treatment, but she didn't like her smile. She cannot eat. She didn't like her mouth. So she came because she started feeling something uncomfortable between the center. I asked for panoramic and 2 X-ray. And what the patient need? The same thing. The patient, she's asking here to reduce cost because she paid too much money to restore her smile, to restore her mouth. She's asking to reduce healing time. She's asking to the comfort after surgery. And especially she's asking for minimal invasive surgery. She doesn't want any traumatic technique. This time, I cannot say what Rodney Norman said because this time I know the OssBuilder. I know about how to go with lateral bone augmentation using minimal invasive surgery technique. I know that I can put the implant at the same time make the lateral bone regeneration. So I managed to convince the patient that I can treat her mouth, the surgery technique, with minimal invasive surgery procedure. How will it start? Look, I disconnect the crown and I have the implant outside the crest. That means we cannot use anymore this implant. What we should do? I will disconnect the abutment and then I will cut the implant because I don't want to remove the implant. I don't want any traumatic and aggressive technique. I disconnect the abutment, cut the implant, take a connective tissue from the tuberosity and cover the surgical site. And this is what I did. The soft tissue graft obtained from the maxillary tuberosity presents minimal risk for intra or postoperative complications, leading to reduced patient morbidity. So I disconnect the abutment and I cut the implant to avoid any traumatic and aggressive treatment. I take connective tissue from the tuberosity and I cover this implant. I cover the surgical site. This technique presents minimal risk for intra or post-operative complications. After surgery, no bleeding, no pain, no complication. So the patient decides to continue her treatment. A CBCT image was taken to evaluate available bone at the site. So remaining bone at premolar side 2.2 millimeters. Molar side 4.8 millimeters. So I have various augmentation technique to treat this patient. I can start with bone block or bone material covered with titanium membrane or PTFE membrane. We can use the ridge split chaser technique. We can put the implant at the same time with this technique, but it's a very traumatic and aggressive technique. And I promise the patient I will not use any traumatic and aggressive technique. So I will go for the minimal invasive surgery. I open a very small flap just to can see. I have remaining bone 2 millimeter. I make my drilling. I put 2 implants and I decide to leave. Palatal bone 1.5 millimeters. I don't want to make a palatal flap. I have exposed threads 4 to 5 millimeters. It's normal because I have severe bone resorption. So I check my surgical defects, my surgical site defect. I put the bone graft 4 to 5 millimeters. I cover the exposed threads, and I choose to use the 3-wall membrane because I have buccal, proximal, and palatal defects. Here, I make a very, very small palatal flap just to can put the portion palatal of this membrane. After fixing connecting this membrane, I can make a very minimum releasing incision to cover the surgical site. Post-op, no complication. Little pain, just she took paracetamol. No bleeding, no edema, no swelling. This is the case after 2 implants with the membrane covering the bone defect, and this is the implant, the cutting implants. 4 months, she came for checkup. At 8 months, she came also for checkup. At 8 months, I make my CBC control. And look what I have. At CBC control, here I have exposed threads. At 8 months, I have 3.2 millimeters bone gain. And I have bone outside the membrane. Look here, bone outside the membrane. Bone outside the membrane, bone gain, 3.2 millimeters, 3.3 millimeters, bone outside the OssBuilder, same, bone outside the OssBuilder. So after checkup, after control, the patient, she traveled, she returned to her country. After 1.5 years, she returned with central lateral in her hand. Look here what I have. I have sealer. She tried many times to seal with many different sealers to seal or to reconnect her central or lateral, but she failed. She came with central lateral with her hand, with the fracture of central, fracture of lateral. I proposed to take off the central lateral to extract the remaining root and put 2 implants. And this is what I did. I extract the central lateral, put 2 implants with 2 healing abutments. So after 4 months, that means after 1 year and 9 months after the first surgery, 2 implants with OssBuilder, bone grafting, the cutting implant, the new 2 implants. These are the results. After 1 year, 9 months, control, and we decide to take off this membrane using the minimal invasive surgery technique. Here I use my blade number 11 for very precise and limit incision. Just incision to can see the membrane and to can disconnect the healing. Very limit and minimal incision, minimal invasive surgery. So disconnect the healing and take off the membrane. It's so easy to take off the membrane with minimum invasive surgery, minimum flap. And look what I have here. The bone outside the membrane, look at the bone outside the membrane. Even we have bone outside the membrane, it's so easy and simple to take off the membrane. This is the membrane. We take it off. And this is the results. Look how we start. After 8 months, we have the new bone regenerate. And the neck of the implant, it's 1 millimeter under the new bone. These are the results. This is membrane. We connect the healing abutment. And after 2 years, we check the bone. We have 5 to 6 millimeters lateral bone regenerate. After, I connect the temporary crown for the patient, and after finishing the surgery procedure, the patient was referred to the prosto treatment for the full ceramic in the upper jaw and to change the removal prosthesis in the lower jaw. Second clinical case, look at this patient. She came with discomfort sensation on the premolar. After the clinical exam, I have 10 millimeter pockets. That means I have a fracture. We talked to the patient that we should take off this premolar, we have fracture, and put an implant. She accepted, and she told me that she will return to extract the premolar. She returned after 8 months, this time with 12 millimeters. So she came again to extract the premolar. She go and she recame after 12 months. Look what we have. starting have bone resorption. And she's very embraced. So she decides to extract the premolar. She returned after 15 months to extract the premolar. And after extraction, severe bone resorption. She returned after 1 year to restore the missing premolar and molar. And look at the concavity here, severe bone resorption. A CBCT image was taken to evaluate available bone at the site. Available bone, premolar region 2.9 millimeters. At the molar site, 5.1 millimeters. So I start my minimal invasive surgery. I put 2 implants. I should have my primary stability, and I have my primary stability. I have exposed threads, surely because I have severe bone resorption. Here, no need for vertical bone augmentation, no aesthetic zone. Just I want to make the lateral bone augmentation to recover the exposed threads. I put my implants and I check my surgical site defects. I connect the anchor. I choose to use the 3-wall membrane. I cover the exposed threads using the xenogenic bone. I connect or I cover all the surgical defects using this membrane, and I stabilize this membrane using the cover cup or the healing cup. And I cover all the surgical defects using the collagen membrane. The advantage of using the collagen membrane to cover the surgical defects, we have explained this in the part 1. So post-op, look, little swelling, little pain, no discomfort after surgery. After 2 weeks, the patient comes for checkup, and after 4 months, no more concavity. After 8 months, the patient comes for control. Look how I start. I take my CBCT. I have 3.1 bone gain after 8 months, where I have exposed threads. So I start my minimum invasive surgery technique to remove my membrane using my blade number 11. Very small flap, very small technique, very minimum incision, just to can see the membrane. And when I saw the membrane, it's so easy and simple to take off this membrane. Look how it's very easy with minimum invasive technique. So I disconnect the healing cup and I disconnect the anchor. So how we start like this? This is membrane with the accessories. And after 2 months, I will check the bone. I have 4 to 5 millimeters lateral bone regenerate. I connect my healing abutment. After 4 months, we start to take the impression. Here we connect the transfer abutment and we connect the crown. And here, after 1.5 years, look, we restore the occlusion of the patient with minimum invasive technique for the lateral bone augmentation. Third clinical case. You know, sometimes our colleague referred for us the patient to put an implants. And sometimes our colleague called us to move from our clinic to his clinic to put the implants. He got his own implants. He got his own accessories. And I take with me my instruments that need my bone grafting, my membrane. In this case, my colleague sent me this picture. I have severe bone resorption, and look at the CBCT. I have my premise. He said he will give me his implant. And I took with me my accessories, my bone, and I put the implant. I restore this concavity using my bone. And I use the OssBuilder to cover the surgical defects. And I try to connect the OssBuilder using my instruments. And look what I have, a gap. I have a gap. Last time, we answered two questions. The OssBuilder can be an alternative method to the lateral bone augmentation while implant placement. And I say yes. I demonstrate that the OssBuilder can be an alternative method to the lateral bone augmentation while implant placement. The second question answer, the GBR OssBuilder can be effective and less invasive than other technique. And I said yes, the GBR OssBuilder can be effective and less invasive than other technique. And last time we talked about the porosity, the indication, the advantage of different diameter in porosity in this membrane. Today we have two important questions we have to ask. Can we use the healing abutment instead of the anchor to connect the membrane? And the second question, can we use the OssBuilder on all kinds of implants? These two questions are very important for the conditions for success and the treatment needed to achieve the desired bone volume. For the first question, here I use my Wassim implant. I use the anchor because the anchor is designed to be connected inside the Wassim implant. I use my Wassim implant, I use my anchor, I put my bone grafting around the implant and around the anchor. And I cover all the surgical defect using the OssBuilder, and I stabilize the OssBuilder using the healing cup. And after healing, look what I have. The neck of the implants, it's 1 millimeter under the new bone level. And the new bone regenerate, it's 5 millimeters. This case, I didn't use the anchor. I used the healing abutment instead of the anchor. And look at the results. The neck of the implant is at the same level of the new bone level. Why I have these two different results? You know, when we have to use the Austin implant, it's a switching platform implant. We have difference between the switching platform and the normal platform. When we have to use the normal platform implant, all the occlusal force goes between the center and the neck of the implants. Look here, the occlusal force goes between the center and the neck of the implant. That means increase the fracture risk of the neck of the implants. But when we have the switching platform, the occlusal force goes toward the center of the implants. The occlusal force goes toward the center of the implant. That means decrease the fracture risk of the neck of the implant. And when we have to use the normal platform, the occlusal force goes outside around the neck of the implant, and that leads for bone resorption. When we use the switching platform, all the force goes vertically. That means very less bone resorption or remodeling around the neck of the implant. And that's why I show you these two photos. I use here my implant, this switching platform. Look at the bone remodeling around the neck of the implant. And here they use the normal platform around the neck of the implant. That means when we have to use the Austin implant, automatically you will drill 1 millimeter under bone. It's automatically you will drill 1 millimeter under the bone level. This is the normal bone. No need here for bone regeneration. No need for bone grafting. You will drill automatically 1 millimeter under the bone level. And when we have to place the Austin implant, you will go to place the implant 1 millimeter under the bone level because it's a switching platform. You build automatically, the implant will be placed 1 millimeter under the bone. This is a normal bone. That means I place my implant in the right position, in the right place, not where I have bone. I should place my implant in a normal position, normal place. Surely I will have exposed threads because I have severe bone resorption. I connect my anchor to my Austin implant. I put my bone material around the threads, exposed threads, and around the anchor. I cover my surgical defect using this OssBuilder, and I stabilize my membrane using the cover cup or using the healing cup. This is video animated, exposed threads. I connect my anchor and I cover all the exposed threads using my bone, the bone material. After checking the surgical defects, I decide here to use the 3-wall membrane to cover my surgical site. I cover my surgical site with this OssBuilder and I connected with the anchor using the healing abutment or the cover cup. So after healing, I have to remove the healing and I have to disconnect or to remove the membrane and disconnect the anchor. After removing the membrane, After disconnecting the anchor, I will have the neck of the implant 1 millimeter under the new bone level because I put the bone around the exposed threads and around the anchor. After healing, I will have the neck of the implant 1 millimeter under the bone level. Here, I didn't use the anchor, so after healing, I will remove my healing abutment, and after healing, the neck of my implant will be at the same level of the new bone regenerate. And this is the results after healing. This is after surgery, and this is after surgery. So we should use our anchor. It's better to use the anchor and to connect the membrane to the anchor by using the healing cup. After disconnecting the healing, we disconnect the anchor, and it's so easy to take off the membrane. No need force, no need. It's so easy. And when we disconnect the anchor, the neck of the implant will be 1 millimeter under the new bone level. So in this case, we saw it. We have to make our minimum invasive surgery. We disconnect our anchor, and this is how we start. This is membrane with the accessories. This is the anchor. This is the healing, and this is the results. The neck of the implants 1 millimeter under the new bone level. The second question: can we use the OssBuilder on all kinds of implants? We return to this case. Here in this case, we cannot talk about all kinds of implants. Here I will explain what happened with me. This is experience happened with me. I use X implants, I put my implant, and I try to restore this concavity by using the OssBuilder. And what happens? The gap. Why I have a gap? I try to make my own experience to explain what happens. I have a dummy implant with external connection. I try to connect the implant to this implant, and look what I have. I take an X-ray. I have 2 millimeter distance between the neck of the implant and between the anchor. Why? Because the internal connection, the internal threads of this implant, it's not made to receive other accessories for other implants. And that's why I cannot connect the anchor to this implant. And that's why I have a gap here, because the internal connection of this implant, it's not made to receive other accessories of another implant. And that's why I have a gap here. I try to connect this anchor to other implants, for example, internal connection, other internal connection. And what I have, I can connect the anchor, but I have a switch here. I have a switch here. I take an X-ray and look, I have a gap here. I have a gap here. I have a gap here, and I have a gap here. That's why the internal connection, it's not made to receive the accessories of other implants. And this was demonstrated by this experience made by Antonio Scarano. He showed us the internal connection of different kinds of implant. Look of the internal connection of this implant, of this implant, of this implant, and of this implant. There is many different internal connection and internal threads. That means, look at the screw of Ostem. The regular is different than the mini, different than Astra, different than Stroman, different than Megagen, different than Glockner, different than Replace, different than the anchor made for Ostem. That means when we have to fix this membrane and to connect this membrane to the anchor, we should connect this anchor to the Ostem implant made for Ostem. The anchor is made for Ostem. We can connect this membrane to the anchor and to fix this membrane using the healing cup. And this is the results. This is the Ostem implants. We connect the anchor. It's well connected and no gap. And this is the results, bone remodeling around the implants. Here in this implant, I try to connect my anchor. I have a switch here. And look at the results. The results, bone resorption. The bone resorption, not because I use the anchor, because I use a machine surface here. But if I decide to use the healing to this implant and to connect this membrane to this implant without using the anchor system, so I should try. Look, I try to use this in the healing. We cannot go inside this membrane because this membrane, the whole of this membrane, it's not made to be connected to this healing abutment. So I should remove and go to the anchor to connect the anchor to other kind of implant. But we should know all that we cannot enlarge the whole of the OssBuilder with the thickness of 0.3 millimeter. So the answer, yes, you can use the OssBuilder on X kind of implant, but before you use it, you shouldn't try it out of the surgery because you don't have because you don't want to have surprise in your surgery. Try to connect it out of the surgery on a dummy implant, on X dummy implant. If you can connect the anchor on this implant. So you can go and you can try it. You can do your surgery and use this OssBuilder on X kind of implant. In conclusion, lateral bone augmentation can be a very simple procedure for the clinician. Ideally, this technique should facilitate the goal of reach with increase while reducing inflammation and postoperative pain for the patient. So to avoid stress during the surgery, it's better to proceed like this. In conclusion, how to proceed? Look at this patient. She has a problem on her premolar, swelling on premolar. We take an X-ray panoramic. We should extract the premolar, extract the molar, and put two implants. So I promise the patient that we can make very minimal invasive surgery technique. So we extract the premolar, the molar, and I go for socket preservation, putting the bone material, the grafting material, and cover with collagen membrane. After 4 months, the patient return. After 4 months, we take a CBCT, remaining bone 2.4 millimeters on premolar region, and we have 5 millimeters on the molar region. So we proceed to our surgery, minimum invasive surgery, minimum invasive technique, minimum incision. We just open a flap just to can see, minimum flap, just to can see the surgical defect. So we put our implant in the normal position. No need for vertical augmentation. Just here we have exposed threads. We have lateral bone augmentation. We put the implants in the normal position and we connect the anchor. Here we connect the anchor to this implant and we check our surgical defects. Here we have one wall defect. So I check my surgical defect and I decide to use the one wall technique. I can cover the surgical defect with 10 seconds. 10 seconds to put my bone, my membrane, and I fix my membrane with the healing cup. It took with me 10 seconds. I check my membrane. I cannot move it up and down, but we cannot move it mesially or distally because it's very well connected, very well stabilized. So after, I will start to put my bone material. Look how it's simple, very simple procedure, very simple technique. Here, I want to raise up little my membrane. Why? Because I want to put all my materials. I raise up my membrane, but it cannot move mesially or distally because it's well connected. I put my bone grafting, no empty space, no gap. I put my bone material. It's very simple and very easy. Just 1 minute to put my bone material. After finishing, I will press my membrane to return to the original position. Look how I will press. No empty space and no gap. After finishing, I will cover my all surgical defect using my collagen membrane. So this is after surgery, very minimum invasive surgery for lateral bone augmentation while placing implant at the same time. After 1 week and after 4 months. This is how we start and this is how we finish. So I want to thank you and I'm waiting for your question.
Mm. Okay, thank you, Dr. Wassim. Thank you very much for this very nice presentation. And
Thank
it's
you,
time
Dr. Stephen.
thank you. And it's time for the Q&A session. So we have got a few questions. The first question here, how about if we use the healing abutment of the same type of implants?
I'll show you the healing abutment. We will get the neck of the implant at the same level at the bone, new bone. That's why we should use the anchor because, to have the neck of the implant 1 millimeter under the new bone. It's better to use the anchor than the healing abutment.
Okay. So also
The
we
anchor
have
is made, sorry, Dr. Stephen, the anchor
yeah,
here
sure.
is made to be used before the surgery, when we have to make the bone grafting and use the OssBuilder. It's made for this.
Okay, thank you, Doctor.
Thank you.
We have also received a question. So someone is asking, so can we have vertical bone augmentation using OssBuilder or only lateral?
No, yes. I talk here about the lateral augmentation, but there is an OssBuilder designed for vertical bone augmentation. Yes, there is OssBuilder for lateral bone augmentation, and there is OssBuilder for vertical bone augmentation. Yes, we can make the vertical. It's so easy like the lateral bone augmentation. It's two different technique, two different membrane, but like this membrane, it's a preformed design. No need for tripping, no need for cutting. You can take the measure, you can check the surgical defect, and you can make the vertical bone augmentation using the OssBuilder for the vertical bone augmentation. This the OssBuilder is designed for lateral bone augmentation. Yes, you can make the vertical with this. Yes, not with this, with other membrane. Yes, two different membrane.
Okay, thank you. Thank you very much.
Thank you.
We have
It's a
also
very easy technique also. It's a very easy technique even for vertical bone augmentation.
This will be similar technique or
Yes, it's the similar instruments, the similar,
the
but
same technique?
different in surgical way, little, but it's the same technique. Yeah.
And it will have the same connection, the anchor, then the OssBuilder,
Yeah,
then
yeah,
the
we have
screw.
we have little varies because it's vertical bone augmentation, not the same anchor, but we
So,
have we have the membrane designed for vertical bone augmentation, and it's so simple technique also.
okay, hopefully one day later we have a presentation about the vertical one.
Yes, we can prepare sometime. Yeah, someday. Yeah.
Yeah. Okay, we also have a question about the anchor. Does it have different heights?
Yes, of course. Yes, this is a very good question. Yes, we did. We have different height of anchor, like we have different size of membrane. We have different height of anchor and difference from the surgical side. Yes, of course, we have different height of anchor. Yes.
Okay, and does the anchor have platform switching or only the implant and the abutment?
I didn't understand the anchor.
Because the Ostem implant, it has platform switching when we use our
Yes,
abutment.
yes.
So does anchor has platform switching or is it important to have?
The anchor is made to regenerate bone around the implant. The final results, the neck of the implant should be 1 millimeter under the bone. That's why we should use the anchor. We should use the anchor. We should regenerate bone around the ankle.
So does it have platform switching?
Yes, it's platform switching. It's designed for this.
Okay. Okay, so we have also the one question. What kind of bone you are using with mesh? He's asking about the bone graft material.
Oh, you can use each bone you want. There is no special bone. You can use the bone grafting is another subject. You can use any bone you want. There is no precise bone to use it. You can use any bone.
Okay, we also got a question. Okay, but how is it with the lower jaw? the lateral bone augmentation, the anchor it on the implant, but the bone will go down. Is there anything will stabilize it apically?
Yes, look at the design now at my screen. Look at the design at the lower parts of the membrane. We can go a little back. Look at the design of the membrane. You see the design of this membrane? The lower design can hold the bone. The bone cannot go outside. That's why this membrane does not trimming or cutting. We can use it like this. The lower part can hold the bone, and even the lateral part, mesial and distal, can hold the bone. The bone cannot go outside.
Okay. Also, we have one last question. So, do you recommend we place the bone graft after or before the placing the OssBuilder?
No, like I show you, it's so simple, so easy, and so simple. Put the implants, connect the anchor, choose the adequate OssBuilder, connect the OssBuilder, stabilize the OssBuilder, and you can move it up and down. You cannot move it mesodistally. Just move it up, put your bone grafting, and put as an original position. It's so simple, so easy, and so simple, and take with you 2 minutes maximum. No, I prefer to fix the membrane than, like I show you, put your bone graft.
Okay. Sorry, but how about the
And
success
try
rate?
it to use it. Try it to use it. I can guarantee for you, you will have a new bone regeneration after this, even the first time. You can try it. It's so easy and simple technique for lateral bone augmentation.
Okay. Also, we have the from Dr. Sulaiman, the question about how about the success rate? Is there research like it's new in the market?
No, until now, there is not too much research about this, no. But there is research, but not too much. This is titanium mesh. This is like a titanium, like other titanium membrane. It's a membrane, titanium membrane.
It has the same concept like other membrane,
Yes, but
but
it's
it's
designed to
3D.
be fixed. It's designed to be fixed on the implant, and it's designed not to be trimming or bending. We have different measure, different form, different shape. It's well designed. The other membrane is not well designed. You can cut it, you can trimming, you can fix it with pins or with screw. This membrane you don't have to fix with pins or screw. That means you don't have to make a large surgical defect. This is an important thing. You don't have to make a large surgery, a big surgery. Just a very small incision, very small flap. You can see it. You can put the implants, put your bone grafting, and cover with this membrane. For it's designed for minimum invasive surgery.
Okay, I think it's very clear. Okay, we have.
And you can use it for different implant, not for just one implant. If you have, for example, 1, 2, 3, 4 implants, for example, upper jaw, you have severe bone resorption for all the upper jaw. You can use on many implants. Each implant you can put for each implant, you can use the bone grafting, and you can cover the OssBuilder. Not designed for one missing teeth. You can use it for example, 2, 3, 4, 5, 6, 7 missing teeth.
Okay. Okay, and the bone is important because the size of the granules varies. So what is the best size of the holes in the mesh?
We talk about the porosity. That means the porosity. Yes, the porosity.
The porosity, yeah, because he's asking about the best size for the holes for the
Yes, we talked
porosity.
last time too much about the porosity. We demonstrate why we have, for example, the 0.6 millimeter, 1.1 millimeter. You can go on YouTube. You can see it. It's on YouTube. Our first presentation. We talk too much about the different porosity and which one we can use it or why the advantage. It's not 0.6. The normal one it's 0.6 millimeter, 0.7 millimeters.
Okay. Okay, I think that's all the questions we have for today. Anyone has any question, you can freely write down in the chat section. Thanks for your question, Dr. Suleiman. Thank you. Okay, so I think we don't have more questions. So we thank you very much, Dr. Wassim, for this very nice presentation and showing us this new product in the Middle East. It's very, very interesting product because of it's minimally invasive and it can reduce the anxiety of the patient.
Yes, of course, this is the problem, the anxiety of the patient. When you told the patient that I want to use for you, for example, I want to make the bone grafting. Not all the
Yes.
patient accept the bone grafting. Bone grafting, you can put an implant, but we need the bone grafting. Yes, and I show you that more than 40 to 50% of our implants or our surgery need bone grafting. Need bone grafting. And by this, the patient, when you told the patient that we're gonna use bone grafting with minimum invasive surgery, you will accept.
That's correct. Okay, thank you very much again, Doctor.
Thank you, Dr. Steven. Thank you, Dr. Tarashmi. Thank you, Austin team. Thank you very much.
Okay, before I wrap up, I want to show everyone our newsletter for this month. So we have the OSMEM on the right side. You can see this one. We can use it also with OssBuilder, as Dr. Wassim already explained. He can use the membrane over the OssBuilder to have better quality of the bone. And of course, we have our last kit. This is a very nice kit with a stopper for the lateral approach sinus lifting.
This is also minimum invasive surgery for sinus surgery. The same.
Exactly.
This is minimum invasive surgery for sinus surgery, lasket and casket.
Exactly. Minimal and very safe because this kind
very
of
safe because of stopper. Yes, yeah, very
we
safe.
are not using round bears anymore. Okay. Also, I would like to announce about our next webinar. It will be with Dr. David Chang. The topic will be navigating complexities, strategies for addressing challenging situations during oral rehabilitation. You can scan the QR code here on the right side of the page to register. This will be in 13 August. So after like 3 weeks, maybe from now, 19 in the UAE time. So save the date and save the time. And we hope to see you all again there. Okay, so thank you everyone for today, and thank you very much, Professor Wassim, for this the two presentations, the part 1 and part 2. It was very, very informative and very interesting lectures, and I'm sure many of us are very curious about this. They want to try it by themselves.
Yes, yes, you go and try it. It's very easy and important products. Yes, try it. Try it for one implant at first, and you will see the results.
Yes, sure. Okay, thank you, Doctor, and thank you everyone for coming today with us. And it's our great pleasure for us. Hope to see you again in 13 August. Okay.
Thank you, Dr. Steven. Thank you very much.
Thank you very much.
Thank you.
Thank you. Have a good day. Have a nice weekend, everyone.
Thank you.